Good evening, everyone. I hope you can all hear me loud and clear. Welcome to the bi-weekly KSA meetings. Today's topic will be on sedation in the ICU. I believe currently we have enough people to at least go ahead with the meeting as we want to observe time today. So my name is Dr. Oduor. It's a pleasure to be part of this session today. And I'm an assistant in the University of Nairobi, currently in my third year. And it's an honor to share this session with you guys. So let's hope to make it a very productive one. So the main focus of today, as I mentioned, will be on sedation in ICU, presented by Dr. Sheilah Gitau and our panelists, Dr. Nyamai and Dr. Adembesa. I think I'd just like to, first of all, before we start, I'd like to thank each and every one of you for at least participating in this session to current session about the country. So thank you for joining. Also, on top of that, I just want to mention a few rules before we begin. Kindly, the size participants, kindly just mute your mics and shut down your videos to just minimize any disruptions or any interruptions we might have. Also, just like for anyone who'd be interested in this session later, you find them online, be it on the website, the KSA website, be it the Facebook page or the YouTube channel as well. So that's just a kind request before we begin. Once more, thank you all for participating in this. And I believe once Dr. Sheilah has a slide presented, we can begin the session. So as she's handling that, I'd just like to introduce Dr. Sheilah Gitau. She's a consultant anesthesiologist currently working in the Kenyatta University Teaching, Referral and Research Hospital in Nairobi, Kenya. I've had the pleasure of working with her personally when she was in Kenyatta and in her current station, and she has excellent insight in the field of intensive care, I should add. So Dr. Sheilah Gitau, once you're ready, kindly just project screen so that we can begin the session.
So good evening. Thank you for attending this webinar. As I'm introduced, my name is Dr. Sheilah Gitau, and I'll be taking you through sedation in critical care. So we're going to go through an introduction of what sedation in ICU entails, go through a few indications, go through the current guideline and recommendations, touch on the scoring systems that are available, and a few medication overviews, and then we shall conclude. It shall not be a very long presentation. So what is sedation? This is the art of depressing a patient's awareness to the environment and reduction of his or her responsiveness to the external stimuli, while retaining the patient's ability to independently and continuously maintain an open airway with a regular breathing pattern. Patients are able to respond appropriately and rationally to verbal and physical stimulation. So why do we need to sedate patients in ICU? There are very many reasons why we need to optimize sedation for patients. One, for comfort for all the things that we do to patients in the critical care. We are doing procedures, we put patients on mechanical ventilation, they're in the same position for hours on end. All these can be very uncomfortable for the patient. And depending on the duration of illness, patients end up with critical care outcomes because they're uncomfortable and there's a lot of awareness that happens. So we need to control all these dynamics as the patient is in the ICU. So initially we used to say only for endotracheal tubing, for patients who are intubated, those would get sedation. But nowadays we have patients on mechanical ventilation who are not necessarily on invasive ventilation. We have non-invasive ventilation, which is still quite uncomfortable for some patients. It makes them very agitated. And these patients, for optimization of their ventilation, we then need to give them some form of sedation. And also for ventilator synchrony, and also for just a simple thing as having sleep. for patients who are in critical care becomes a very important dynamic that needs to be controlled. So what are the spectrum of things that we do with our sedatives? We give anxiolysis, which is relief from apprehension and agitation, which means that the patient has minimal alteration in their sensorium, but they're able to be calm. Some of them we want to give amnesia. We've intubated the patient, we've been doing painful procedures on them, catheterization, some memory loss for some time can be useful for these patients. We need to control pain because pain can lead to agitation, can lead to delirium, and hence our sedation needs to be intact. But at the same time, especially for non-intubated patients, you want to maintain their sensorium. You don't want them to have altered sensorium because sometimes just that change in the psychological state of the patient can lead to hallucinations and poorer outcomes. And sometimes you want to give anesthesia. Maybe you're doing a tracheostomy and you want to give, and the patient needs adequate pain control, and you want to maintain some anesthesia where there's loss of sensation and motor activity so that the surgeon can also continue with the procedure. So then comes in this something called the ICU Triad, where patients will go through pain. Pain will lead to delirium. Delirium will lead to agitation. And all these, it's sort of a pyramid where one thing leads to another, or one thing will be caused by another. And this could be through a multitude of triggers. One of them could be neurological diagnosis and neurological disease. A patient with a head injury who comes to the ICU with that altered sensorium will be agitated. And once the patient is agitated, we then give them physical restraints, which could lead to pain. And then once the patient has had pain for a prolonged duration of time, they end up with delirium. So we need to, and before we can optimize sedation, we need to rule out pain as a cause of our agitation or delirium as a cause of agitation. So that's why you have to look at it as a triad, because one thing leads to another, and you need to control, especially pain, before you start sedating a patient, because that will lead to poorer psychological outcomes for the patient, because they're in an immobilized position, they can't communicate their pain, and therefore that worsens their outcome by giving them delirium, and the post-ICU syndrome could also be an outcome of that. So, as we've already said, some of the indications from starting sedation. We said about mechanical ventilation and the anxiolysis, amnesia, and analgesia aspect, but what about decreased oxygen consumption? Patients who are in the ICU who are in pain will be tachycardic, will have elevated blood pressures. All of these lead to increased myocardial oxygen demand and supply, can trigger even a myocardial infarction. You want to maintain oxygenation just adequately. Some patients are very agitated. Maybe the patient has come in, he's tachypneic, he has dyspneic, maybe a patient has pulmonary edema. Put them on the non-invasive ventilator, but they're still having the tachypnea, they have increased work of breathing. You want to rest those respiratory muscles because you don't want respiratory muscle fatigue. That in itself is an indication for you to start sedation. There's a patient who comes in with head injury, has that altered sensorium. Neurological status is about 12, 13. They're restless. They're likely to cause harm to themselves. They're likely to have accidental invasives removal. Endotracheal tubes especially would be of quite of importance to us. They might remove their catheters, cause urethral injury. These are reasons to keep a patient calm and sedated. It also allows you to enable you to wean the patient off the ventilator. Patient who has been on volume control or assist control ventilation and has had all the work of breathing done for them. Once you start weaning them, sometimes they start getting diaphoretic, they're restless, they've come from a state where they were completely asleep, and now you're starting to let them do a lot more work of breathing. These patients can get a bit restless, and this will allow you to manage your patients from invasive ventilation to less supportive modes of pressure control, ventilation, pressure support, and eventually to extubation. And indeed, we do extubate patients on sedation. Dexmedetomidine is one of the drugs that we tend to use for that because of the rapid onset, and it causes a very nice anxiolysis, and the patient can be extubated comfortably. Remifentanil can also be used for that, so that you're able to wean the patient to extubation. Also for efficient care of the patient who's fighting and is agitated, restless, jumping all over the bed, the nurse will not be able to do her medications. So, and also for the nursing safety, because the patient might cause harm to the nurse or to the caregiver when they're there to do some of the procedures. Then for neurocritical patients with raised intracranial pressure also has been indicated. And also for induction of sleep. Patients in the ICU have an altered sleep-wake cycle. The lights are on all the time. Either lights are on during the night, during the day, many people coming in and out doing many things. They're not able to sleep. Long term, this leads to adverse psychological outcomes. So you want to induce the sleep so that, and also to reduce the risk of delirium. You will induce sleep. Sleep helps the patient have their normal sleep-wake cycle. So it's not all 24 hours a day, all that constant stimulation. And also noise, of course, there's a lot of noise in the ICU, so the patient needs to sleep. Of course, we talk about tolerance of invasives, such as urethral catheters and nasogastric tubes. Facilitate some of our like therapeutic hypothermia. It's not very comfortable, the patient will start shivering. So sometimes that sedation will help you facilitate your cooling for that 24 hours that you need to do it. And of course, the associated long-term psychiatric outcomes. And also the family will be more accepting when they come and find their patient calm, vis-a-vis when they walk into the room and the patient is pulling at everything. It also causes them some distress, also for comfort of the people coming to see the patient. So consequences of uncontrolled pain and anxiety, and we said pain, anxiety and delirium. I mean, anxiety and delirium will be in the same paradigm. You have stimulation of the autonomic nervous system, which will release humoral factors leading to increased heart rate, blood pressure, increased myocardial oxygen consumption, which we said can lead to ischemia and myocardial infarction. You have the stress hormones, which lead to insulin, release of stress hormones such as norepinephrine and epinephrine, which lead to catecholamine surges, insulin resistance with increased protein metabolism, hyperglycemia. And we know hyperglycemia in critical care patients has been associated with poorer outcomes. You want to optimize your glycemic control, so reduce the stress. Altered hormonal responses also lead to increased factor VIII and fibrinogen levels and platelet activity, which can lead to a hypercoagulable state. So in as much as the patient is immobilized in the bed, also because they are stressed out, they have all those hormonal changes, they're in pain, they're agitated, it can lead to increased risk of DVT and PTE. Also, there's you'll have immunosuppression with a reduced number and functionality of lymphocytes and granulocytes, which you want to control because already the patient is in ICU with all these invasives, the risk of infection is higher among these patients. So keep them well controlled in terms of the psychological stress, which will reduce the immunosuppression. Then you have mental disturbances such as hallucinations or vivid nightmares. Sometimes we do painful procedures to patients who are sort of half awake because they're very light or they're awake. And all these lead to nightmares. And patients who have been discharged from ICU have been found to have the post-intensive care syndrome, where the long-term outcomes, I think the 1-year mortality was actually up to 12% and higher in medical patients who had up to 39% mortality because of the post-ICU syndrome, which was associated with poorly controlled sedation, okay? So what do we want to do? You want to control pain, control adverse effects of the drugs that you're giving. You want to use the minimum possible dose of your drug to achieve the benefit that you have. So then comes in the same concept of multimodal analgesia, then comes in with multimodal sedation, where if you can use 1 or 2 drugs to control pain, agitation, and movement, then it's better than using a higher dose of 1 drug to do the same thing. So that is where drugs like propofol, which has been used quite, now ICUs quite freely, is not exactly the most ideal because it doesn't control pain. So you would then combine something like, a drug like dexmedetomidine, which has both sedation, anxiolysis, and analgesia, becomes a better drug because you can use it for the same, to control both pain and analgesia, as opposed to propofol, which is only good for sedation. So what depth of sedation do you want for patients? Do you want the patient lightly sedated or deeply sedated so that you can do everything that you want to do? So the ideal is, so there's a spectrum of sedation that you could use. You could do minimal sedation where you only do anxiolysis. Patient is awake, patient is able to communicate, patient is able to, they're able to communicate, they can, and they're rested well on the ventilator. This is the ideal situation. You could have moderate sedation where the patient is full, that is for the patient on minimal sedation, is a patient who's like on a CPAP, continuous positive airway pressure ventilation. Patient is doing most of the work of breathing, getting minimal support from the machine. Moderate sedation is this patient who has been on ACVC and now you've changed to something like SIMV for those who use SIMV ventilation. So the patient is doing a lot more work of breathing, but you want them comfortable enough to tolerate the ventilator. So they will respond to verbal or tactile stimulus for a few seconds and then go back to sleep. They can maintain their airway reflexes if they're on spontaneous ventilation, and you have minimal interaction with your cardiovascular system. Then you have deep sedation, where they respond only to deep, repeated, painful stimulus. Maybe we open their eyes for 2 to 3 seconds and go back to sleep. This is where you want your patients who are on full mechanical ventilation, yet it has minimal interaction with the cardiovascular system. Okay. Then the next spectrum would be general anesthesia, which is what we tend to use most in our theaters. The patient is completely unresponsive. They have amnesia, analgesia, and and do not respond to painful surgical stimulation, and they're in a state of unconsciousness. That is where we want patients who are in anesthesia in theater, not the patients you want in the ICU, who you're hoping to transition to liberation from the mechanical ventilator. So there's something noted that was ketamine, which causes sort of a dissociated dissociated state, where they're aware, they are able to maintain their airways, but they tend to respond to stimuli in an inappropriate manner. So they tend to get hallucination. These are drugs that you want to avoid in an ICU where you want your patient who's able to wake up without long-term psychological outcomes. So how do we then assess what depth of sedation the patient is on so that you know what you're achieving with the drugs that you're giving? We have to use sedation scoring systems. They should be simple, easy to perform, non-invasive and reproducible, meaning you can use it across the board. If you say that the patient is at a light level of sedation, using your scoring system, all the patients will be scored the same, helps you get useful data about your patients, and it's reproducible. So of the sedation scoring systems that are commonly used, you have the two that are validated for use in critical care according to the Critical Care Society, the CCM. The CCM, I'll come to that in a little while. Can't remember the full name. So the CCM has recommended using either the Richmond Agitation Sedation Scale or the Sedation Agitation Scale, which is the SAS. So you have the RAS and the SAS. So you can then see where your patient is on the scale. Sorry, something going. See where your patient is on the scale, and you want a patient who's calm and cooperative using the SAS. You don't want them at the extremes. So the patient who's in a deep coma, who cannot be aroused, deep sedation, minimal or no response to noxious stimuli. This is almost general anesthesia. You don't want your patient there. You don't want them very sedated, only wakes up to a few verbal commands. Ideally, the patient should be calm, easily rousable, can follow simple commands, but we give it a range. So you can give it a range of between 4 and 3. 4 and 3 is ideal, 4 the best. You don't want your patient agitated, anxious, fighting, or at 7 where they're even a danger to the staff. When you come to the RAS, which is I think the one I've seen used more commonly, you have the patient who was alert and calm. You don't want them restless or drowsy. You can have them drowsy but calm, but anything beyond moderate sedation, 3, 4, 5, -3, -4, -5, where they're in deep sedation, they are not trials, those end up with long-term, with worse outcomes. And you don't want the patient combative because they're not going to get the care that they need. So you want a score of about 1 to -1. So, and then you have the Ramsay sedation score, where you try to the patient up, you stimulate the patient. First you use verbal, then you use physical stimulation. So if the patient is anxious and restless, his score is 1. You want the patient who's awake, responds to commands, or asleep, but wakes up to a brisk response to light, gabble attack, or loud noise. So 3, 4 would be ideal. You don't want the patient again at 4, 5, or 1 to 2. These are the most commonly used sedation scales, scoring systems. Are they the most appropriate? Are they, they're validated? Yes, but are they able to give you reproducible data for all patients? It has been found that they're not as ideal. They haven't been found to be, I think the level of the level of evidence was a B, 1B, where it can be used, but it's not a level A where you want it to be. So there's something else that you could use. We've already gone through the SAS and the RICA sedation. So, sorry, let me first talk about this slide. So the sedation scale, the daily sedation scales has not been used in all countries across the world. Most people, I think in Africa, in Kenya especially, we're trying to use these daily sedation scales. I think in our critical cares, we try to at least categorize our patients in terms of this. But you find even in the developed world, you see the use of these sedation skills is at best in the UK and Ireland at 72%, and in Austria at 18%. So we are still not doing as well as we could in terms of using our sedation skills. How should we monitor our sedation? So for monitoring of your sedation scale, you want to use something like the bispectral index scoring. This has been found to be the most useful and the most accurate in terms of assessing the depth of sedation. And this is because it calculates, it measures the cerebral electrical activity by an EEG, and then it produces this data in a quantitative number, gives you a number, which you're then able to use on the scale to assess whether your patient is lightly or deeply sedated. And this is the BIS range. So you find at 100%, the patient is awake. At about 80, he responds to voice and to loud noise. So this is ideal for a patient who's anxious. You want them between 80 and 90. Then the patient who has a low probability to explicit recall on unresponsive verbal stimuli. This is now around moderate sedation. So ideally you want your patient between 70 and 80 where they can respond, but they're not, you want light sedation for your patients, okay? And so these are the Society of Critical Care Medicine, of 2013. They came up with a guideline that we have been using mostly in our ICUs to determine what are our goals and what should we be doing in terms of monitoring sedation in our ICU. So they come up with these guidelines, and the level of evidence for this range between 1A and 2B actually. So for the depth and quality of sedation, they recommend that it should be monitored routinely and assessed in all ICU patients. So every day when you see your patient, you should have a sedation score for your patient. You should assess the level of sedation because you want to keep them at light sedation. And they recommended that using RAS, the Richmond Agitation Sedation Scale, and the SAS were the most valid and reliable scales for assessing quality and depth of sedation in the ICU. Okay. They suggested that, but these were not objective, they had a bit of subjectivity, because if I came and saw the patient 5 minutes after the sedative has been increased, I'll find the patient at a different RAS score than before. But what is that going to be the state of sedation throughout the day? No, it will probably be weaned. So they suggested that using objective measures of actual brain function to adjunctively monitor sedations in patients receiving neuromuscular blockade was more ideal, and this is level 2B, for those patients who are not able to respond to light gabella touch because they're muscle relaxant. How deep is your level of sedation? And they suggested that the EEG monitoring either to monitor non-convulsive seizures in ICU patients and to titrate the electrosuppressive medication should be done to achieve burst suppression in ICU patients. Maybe we could remove burst suppression in patients with who are in ICU, who are with raised intracranial pressure, and that is level 1A. Okay. Then they recommend using the lightest possible sedation or use daily sedation interruptions, and this is level 1B. Okay. Use sedation protocols and checklists to facilitate ICU sedation and management. And they suggest using analgesia first sedation for intubated and mechanical ventilation before progressing to muscle relaxation. They suggest, and then we found that patients who were put on muscle relaxants for a long duration of time had critical care myopathy, hence the need for the change in the guidelines so that you just use analgesia and sedation first before you think of paralysis. So suggested that using non-benzodiazepine sedation or either propofol and dexmedetomidine instead of benzodiazepines, which they use, for which they recommended midazolam or lorazepam in mechanically ventilated patients. So as at 2013, they recommended using non-benzodiazepine sedations, avoiding muscle relaxants if you can, recommend bispectral index monitoring for patients who are on muscle relaxants, and used objective scoring systems for measuring sedation, the level of sedation. So what has changed since then? So since the 2013, there was an update in 2018 of the clinical practice guidelines for prevention and management of pain, agitation sedation, delirium, immobility, and sleep disruption in adults, also known as the Padis guideline. And this was there was an update from the 2013, which was mostly on pain, agitation, and delirium only. So what changed in these guidelines? From the 2013 guidelines, they included two aspects, the rehabilitation and immobilization and sleep disruption into the guideline. They included collaborators who are from section chairs to people who work in the critical care unit, nursing managers. They actually included patients who had been discharged from critical care as collaborators and co-authors. And then instead of having it just for North America, they included Europe and Australia. So it had a very large body of data they used. And what did they do? Why was there a need for a change? So they found that the Padis guideline was good for improving short-term patient outcomes. Patients who were in the critical care before up to discharge from critical care were doing well. But what about the long-term outcomes for these patients? They were targeting light levels of sedation and daily awakening trials to improve psychological outcomes, ideally, and to reduce the ventilator days and duration of critical care stay. And they minimized using benzodiazepines, which had more interaction with the liver and urinary, and had genitourinary, renal clearance, yes, because of augmented renal clearance in critical care patients. And the tendency of these drugs to accumulate in the patients, leading to increased ventilator days. They were tending towards avoiding benzodiazepines. But what about the long-term outcomes for these patients? You saw that in the 2018 guideline, when they were coming up with the guidelines, they included patients who had actually been discharged from critical care. And they noted that there was need to improve the post-ICU outcomes for the patients. These are the patients who went home, long-term had post-traumatic distress disorder, had loss of muscle mass when they were in the ICU, and this progressed on even up to a year. They were found to still have lost in significant motor activity compared to patients of their same age who had not been to critical care. So the Padis guidelines now wanted to change the sedation delivery paradigm so that we consider the long-term post-ICU outcomes. They intended to specify the sedation medication choices and the drugs they used. And among critically ill patients, they found that they tried to find out, was light versus deep sedation, did it lead to improved 90-day mortality? Did it reduce time to extubation, time to tracheostomy? Reduce the number of tracheostomies that was done, cognitive and physical decline, as well as depression and post-traumatic distress. So In terms of light versus deep sedation, they found that light sedation was not associated with a reduction in delirium, post-traumatic distress disorder, or depression. So whether your patient is lightly sedated or not, that long-term psychological outcomes will not change. 90-day mortality was also not significantly reduced, with a relative risk of 1.01, and the self-extubation rates were not significant either, relative risk of 2.9. So in terms of a recommendation, they said they would suggest using light sedation versus deep sedation in critically ill, mechanically ventilated adults, because the quality of data that was found was very low quality. I think they had 5, they tried to use randomized control studies for to come up with the guidelines, and they only found about 5 randomized control studies, which was not enough for them to come up with conclusive data. And like they said, they found the numbers were about 1,000 patients, and they found that there was no reduction in terms of mortality. So they won't make it a strong recommendation, because there are other reasons you're trying to use your light sedation. You want to improve the time to not self-extubation, but the ICU duration was shortened when patients were on light sedation versus deep, as was found in the 2013 guidelines. But it did not reduce your 90-day mortality. So they would suggest that you could use it for other reasons, but not for that. And then comes the question of daily sedation interruptions versus nurse protocolized sedation. This is where every time, for a short duration of time, you turn off the sedation and you use an objective scoring scale to measure whether the level of sedation of the patient. So you stop the sedation, and then within a certain duration of time, you try to see whether the patient is arousable, if they're able to follow simple commands. And they found that that had been used before, vis-a-vis the nurse protocolized sedation, where the nurse will use a sedation scale and will try to achieve a certain targeted sedation level based on the scoring system, if and when they went to the patient. So the difference is, when you use the daily sedation interruption, is that you're able to decide at a time what the level of sedation is. Well, with the nurse protocolized sedation, it will depend on when the nurse is available to do the sedation scoring. So you'd find that there'd be discrepancies in terms of how frequently it was done and when it was done. But at the end of the day, they were both found to be safe. Okay, there was none that was best, so that was superior over the other. So whether you do the daily sedation interruption or the nurse protocolized sedation, the outcomes in terms of achieving light sedation is the same and is safe for both patients, for the patient. So again, they did not grade this statement because, again, the level of evidence was wanting, because the nurse protocolized sedation scores would have to be the same in all the studies for them to come up with a level 1 or a level 1B. So they decided not to grade this statement, meaning you could use it if you choose to, but they're not suggesting it as a strong recommendation. What about the choice of sedation after cardiac surgery? So they was thinking that using propofol versus benzodiazepines for sedation in mechanically ventilated patients after cardiac surgery was recommended because of the short onset and offset of the propofol vis-a-vis the benzodiazepines, which can accumulate in the body, the change in the renal clearance. And for this, they found that the propofol was better than the benzodiazepines in terms of sedation in mechanically ventilated patients. So it is a conditional recommendation if other things being fine, like the patient does not have renal issues, patient is not hemodynamically unstable, they would recommend using the propofol. But then again, the quality was not the best, so they're only using it as a suggestion. Then again comes the big question of, what sedation should I use? Do I use propofol over benzodiazepines, which had been recommended in the 2013 clinical practice guidelines? Do I use benzodiazepine, dexmedetomidine over the benzodiazepines? Or is it dexmedetomidine versus propofol? This is now for all patients, medical, surgical, non-cardiac patients. So for the propofol versus benzodiazepine, they found that the time to extubation was actually reduced by 11.6 hours. And the time to light sedation was reduced by 7.2 hours. So there was benefit. For dexmedetomidine versus benzodiazepine, interestingly, there was no significant benefit of dexmed versus benzodiazepine infusion for duration in terms of reducing the duration of mechanical ventilation. ICU days were 0.7 days, or ICU length of stay, median time of 0.2 days, or reduction in the risk of delirium. Remember, we were using dexmedetomidine for anxiolysis because you wanted to reduce delirium in the ICU. There was no benefit in terms of using dexmed or benzo. So if those benzodiazepine, sorry. So if these are your outcomes, these are your goals, maybe then you want to use the propofol instead. So when it comes to dexmedetomidine versus propofol, there was no significant difference in time to extubation. So there's no benefit whether you use one or the other. Maybe use something else like cost to decide what you're going to use. Unfortunately, when they looked at the studies where dexmedetomidine or propofol were used, the time to light sedation was not one of the outcomes that had been assessed. So they were not able to come up with the time to date, the data for these other outcomes. So there's no recommendation of whether dexmed versus propofol is better in terms of time to light sedation. So what do they recommend? They suggest that using either propofol or dexmedetomidine over benzodiazepines for sedation in critically ill mechanical ventilated adults they suggest that you could use propofol or dexmedetomidine over the benzodiazepine, which is not very different from the 2013 guidelines. So now we know what the current guidelines 2018 Society of Critical Care Medicine is suggesting as our choices of medications. What about the objectivity of sedation monitoring? Do you want to use the EEG-based tools such as the BIS, or use the normal heart rate variability, actigraphy, or evoked potential in critically ill intubated patients? So they found that the bispectral index monitoring is best suited for sedation titration during deep sedation or during muscular blockade, which is not an unusual finding. We already knew that. Sedation monitored with BIS compared to subjective scales may improve sedation titration when a sedative scale cannot be used. So in a place where you can't use a sedation scale, you have your BIS monitoring, and that will tell you about your level of sedation. Then they also, in the guideline, they looked at what about physical restraints in the critical care? Have they been of benefit? Should we continue using them? Why do we use restraints? So they found that from the data, I think it was 32 ICUs, they looked at physical restraint use, and they found that they had been used to enhance patient safety and prevent falls. They prevented self-extubation. They were used to prevent self-extubation or tube or device dislodgement or removal, and control patient behavior and protect staff from combative patients. And I think we've all seen these patients who need to be restrained. However, from the data that they found that there were even higher event rates in the patients who were restrained physically vis-a-vis the ones who are not, in descriptive studies though, not randomized controlled studies. So it's possible that having physical restraints is actually worse than for the patient than using chemical restraints, okay? So when they looked at the evidence, they could not come up with the data that they found they were not able to come up with a conclusion about whether you should not use it or not. They found that there were reasons why the physical restraints were used, accidental device removal and endotracheal tube removal, which would be a very critical event for a patient, especially if the patient is on paralytics. And they do not unrecommend using them, which is why it's an ungraded statement. So it's for you to use your clinical judgment to decide whether the physical restraints risk versus benefit for your patient. Okay. And the studies that you used did not demonstrate any efficacy. They did not show efficacy or safety concerns with the physical restraints. So they can't unrecommend it, but I think it's for you to decide whether you want to use a physical restraint or not. So what are the qualities of the sedatives that we use? They should be both, ideally you want to use a drug that has both sedative and analgesic properties, because you reduce the number of infusions you're giving the patient, and therefore the drug interactions will be less. Because if you're using fentanyl or say remifentanil for analgesia and you're using propofol for sedation, And then the two drugs will give you more of a hypotension. You want a drug that's going to give you minimal cardiovascular effects, will not give you controllable respiratory effects, has a rapid onset and offset because of the time to extubation and time to light sedation. You want some that do not accumulate in renal and hepatic dysfunction, have inactive metabolites, inexpensive, and have no drug interactions with other critical care medications. Do we only need to use pharmacological therapy for sedation to optimize light sedation? No, there are other options, especially when in the 2018 guideline, Critical Care Society guidelines, they talked to the patients who'd actually been in critical care. And they found that communication and reassuring for the nursing staff, for the patients, they had they felt better about it. The patients were more comfortable, were able to tolerate therapy better when they were told what was going to be done. You're going to do a painful procedure on the patient. You're going to do a blood gas. Please talk to the patient. Patient is lightly sedated. Explain what you're going to do before you prick the patient. These are the things that were triggering delirium and agitation because of the pain, ICU triad. So environmental factors we should control, lighting, have sleep-wake cycles, have the curtains closed at night, noise control. The noisy places, patient is going to end up delirious. And then a very hot room, patient is hot, they're sweating. All of these had psychological impact on the patient and should be things we can do done pharmacologically to help keep our patients comfortable. And then managing thirst, hunger, constipation, and full bladders. These are simple things that we don't routinely think about when we're when you're looking at a patient who's being sedated. Sometimes you're increasing your sedative dose because the patient has been constipated for 3 days because you've been giving fentanyl without a stool softener. Or the patient has a catheter, but the catheter is blocked. The urine output is low, patient is diaphoretic, but you're not putting everything together. So, and especially these patients who are not catheterized, who get a full bladder because they are on opioids. These are some of the non-pharmacological things that lead to better patient outcomes and post-ICU care. And then now we come to the pharmacological therapy. These are the commonly used drugs. I think we've all used all these drugs. So I'm not going to focus very strongly on them because we've done this before and gone through the drugs. But what do you want to do? You want to minimize the side effects that can come with drugs. And mostly these are cardiovascular, respiratory, and long-term delirium. Patients who are on benzodiazepines for a long time, it has been, and also to some extent, the opioids found to end up with delirium. So you want to reduce use of these drugs for long, because you're looking at the long-term psychological outcomes for the patient once they've left the hospital. Okay. So are there any other things that are being analyzed or under investigation in terms of sedation? Yes, there's a randomized controlled study that's underway on analysis of using inhalational agents and long-term, in terms of ICU sedation and the long-term outcomes. There's also a study looking at the functional status, psychological well-being, and quality of life of patients after ICU care. Sedation with inhaled anesthetics, it is something that is being thought about, readily available. However, I don't know how much it's being used. Once the data is out, we shall share with you. So this is going to be one of my last slides. So in this, when you're assessing a patient who you want to start sedation, remember we agreed we rule out delirium, rule out pain. So first you rule out the reversible causes. Talk non-pharmacological treatment. Is the patient constipated? Does the patient have acute urinary retention? Are they in pain? Is it a fracture? Have we reduced the fracture? Have we, given medications for pain? If the patient is comfortable, leave them. You assess your sedation, your sedation state, and do daily awakening protocols. If the patient is not, and you think the patient is in pain, have you assessed the pain? Use a pain assessment tool so that you can set your goal for analgesia. So your target would be an nonverbal pain score of 0 to 2, or use the critical care pain observational tool and target a score of 0 to 1. Consider the potential causes, treat those causes. And if the patient is in pain because they're constipated or they're in an odd position or they have a fracture, treat the cause of the pain, and then consider your hemodynamics before you start your medications. Are the patient stable hemodynamically or unstable? Stable, you can use your fentanyl, you can use your hydromorphone, you can use your morphine. If they're unstable, fentanyl is a better drug. And then consider your renal impairment before you consider your drugs, fentanyl and hydromorphone. The doses, I think we all know these. I think most of us use fentanyl at 1 to 2 mics per kg per hour, but you can use the doses recommended here on the lower side for us. I think we tend to use up to 5, but that's okay. You can use morphine at 2 to 4 milligrams per hour or hydromorphone at 0.4 to 0.8 milligrams per hour. Oops. So then the primary approach, first, when you're initiating your pain complications, give a bolus before you start your infusion. You want to get over that pain threshold before you continue your analgesics. Otherwise, you'll end up giving higher doses of the drugs, okay? And then you want to look at the signs of, and then once the patient is well controlled, consider weaning down to the lowest dose of the drug to achieve what you want it to do, which is your pain control. So try to reduce, wean off your infusions within 7 days, because it has been found, and you taper them slowly over time as you continue either oral or intermittent bolus, doses of the drug rather than the continuous infusion, especially where opioids are concerned. And once you stop the sedations or your opioids, consider if the patient going through withdrawal. And here are some of the signs: pupillary dilatation, sweating, rhinorrhea, tachycardia, agitation. In that case, you might need to restart your opioids or give them for a longer time and then taper them off. So if the patient is not in pain, by your pain assessment tool, which includes maybe talking to the patient, looking for physical signs of pain, consider now your sedation. Is the patient, but before you start your sedation, again, assess. What is your scale of agitation? Use a sedation tool. Use an assessment tool. You could use your RAS or your SAS. And you want a RAS of 0 to -3 or a SAS of 3 to 4. And then consider the potential causes of the anxiety. Is the patient anxious? Is the patient in pain? Why is the patient anxious? And that's on the first slide with the triad, the ICU triad. So then that leads you to your drug selection. So you anticipate your sedation. How long do you think you'll sedate this patient? Is it going to be 24 hours, less than 72 hours, more than 72 hours? Then you decide what drug you're going to use. So if anticipate less than 72 hours of sedation, use midazolam, propofol, consider dexmedetomidine. If you anticipate longer sedation, 72 hours, their recommendation is lorazepam, which we don't have here in our country. Patient with renal impairment, lorazepam, propofol. A patient who you're anticipating giving it for more than 72 hours, propofol is highly discouraged at high doses of more than 4 to 6 milligrams per hour, because it's been found to cause the propofol infusion syndrome. So then you want to use your other drugs. Opioids are not, you could use your opioids for this instead of the short-acting drugs. So what is your sedation scale? So your RAS of less than 2 with an ordered goal, okay? So you want to use a RAS of greater or equal to 2 levels of where you started. So if the patient is at -4, is at +4, you want them to come to at least a 2 or less. Then I guess we don't use lorazepam, but for propofol continuous infusion, decrease the rate from 5 to 10 mics per kg per minute every 10 minutes until the patient reaches the RAS goal, which you will use your RAS score to determine. And titrate with written orders, not verbal. It should be on the T-sheet what exactly you want them to give. When you're giving opioids, morphine or hydromorphone or fentanyl continuous infusion, you give a bolus and then you hold until the patient reaches the RAS goal. If the patient is heavily sedated and is now at a RAS of -4, you want to stop the drug, wait for the patient to wake up, and then you resume at half the previous dose rate that you are giving. So if you are giving morphine at 5 milligrams per hour, you've held it, patient is now waking up, you go back and restart it at 2 or 3 milligrams per hour. Okay, and then you titrate it in the sheet, in the treatment sheet, and you give written orders to the nurses. Okay, if the patient you've assessed is not in pain, is not sedated, because they're responding inappropriately to your questions, they're not able to wake up for long, they have inattention, consider delirium. Is the patient delirious? Use a delirium scale. The one that is validated for use in ICU is the CAM ICU, which is the confusional assessment method in the ICU, or you could do the ICDC checklist, CDSA. So consider potential causes of your delirium, always consider your causes. And then how are you going to give it? Are you going to give it orally or as a parenterally? So if you're going to use pharmacological therapy, dexmedetomidine, as an infusion, you can go up to, I think we use 1.4, but they use 1.5, 0.2 to 1.5 mics per kg per hour. Consider in patients failing spontaneous breathing trials due to agitation, okay? Because they'll be able to continue breathing on the dexmed. You could also use haloperidol, given IV, 2.5 to 5 milligrams, every 15 minutes PRN, plus, although we tend to use it as a 3 TDS dose with a maximum of about 15. So you can give 5 milligrams, 5 milligrams, 5 milligrams. You can give it either IV or IM for delirium. Okay, so you consider decreasing the dose once the patient is now on the opposite of that delirium score. Patient was hyperactive, is now, once the patient is well controlled, wean it off as well. If you're having a patient who is in hypoactive delirium, the patient who's just flat affect, not communicating, doesn't want to talk, you'd rather use a lower dose of your delirium. According to their recommendation, is to use the lower dose of your haloperidol rather than the 5 milligrams, use 2.5 milligrams. If you're using orally, there's a whole range of drugs you could use. Haloperidol is still one of them, quetiapine and risperidone, and the doses are there. And always consider your non-pharmacological treatments of delirium, which would be daily awakening trials, talk to the patient, they're able to tell them where they are, orient them, tell them the time of day, where they are, perform early mobilization, promote effective sleep, closing curtains, shutting things down, those BP cuffs and painful things that are causing the patient pain, stagger them, how frequently they cycle, perform timely removal of catheters and physical restraints. Once the patient is able to cooperate, which you're assessing every day, stop the physical restraint because the patient will get agitated and then will have to restart your sedation. Ensure if the patient uses glasses, please give them their glasses back and hearing aids, so they're able to orient them in where they are. Minimize noise and stimulation at night, and minimize benzodiazepines for sedation, which have been shown to cause delirium. So in conclusion, when we're starting our sedation, let's not forget the triad: treat the pain, treat the agitation, and before you start your sedation, make sure the patient is not delirious and they're not in pain. Sedation is not the same for all patients. It should be individualized. The patient with head injury who comes in with raised intracranial pressure vis-a-vis the patient who comes in with respiratory failure, those patients will be managed differently. One, you want to reduce the ICP. The other one is for ventilator synchrony. So those patients you will treat differently. And you have to monitor your levels of sedation on a daily basis so that you're able to wean them off in a timely fashion to avoid long-term psychological, physical, and deleterious outcomes, such as the post-ICU care syndrome. And thank you for listening. Those are my references. Back to you, Dr. Abel.
Okay, thank you so much for Dr. Gitau. That was a very informative presentation. I'm sure everyone was as rooted as I was in it. So I think thank you to all for your attention so far. I believe we can move forward to the next session, which is just to introduce our sponsors for this session today. today in collaboration with the KSA webinar organizing team. Just a brief presentation to be made by Lauren Peterson, all the way from South Africa. She's a product manager for Fresenius, and I believe the product at, or rather the product in discussion was supposed to be Propofol. I feel that goes in line with our presentation. I was informed it's going to be a pre-recorded talk, not more than 10 minutes, because they're anticipating a few technical issues on their side. So as it stands, I'll give the floor to our sponsors for at least 10 minutes, and then we can dive into the Q&A session. I've seen there's a number of questions already on the chat, so we should be getting into it as soon as possible. So just a quick message from our sponsors, and then we can proceed. Thank you. Lauren?
Good evening. And
hi,
Maria.
hello. Jumbo.
Hi.
Hello.
Yeah, we pre-recorded the session just in case there were technical issues from our side, load shedding and all of those issues in Johannesburg. We will be around for questions after the presentation, so please enjoy, and thank you for this opportunity.
Thank you.
Yeah, I'm able to see the, I think the page currently is about the history.
Is the audio working?
Not currently, no, I'm not able to get anything. We'll wait for the audio issues to be sorted out. Maybe we can just dive into the Q&A session with already posted questions on the group, and then we'll come back to it if that's okay.
This is fine, thank you.
Perfect. So just to kick off the Q&A session, there was a question that was sent in. So even just before we dive in, I'd like to introduce the remainder of the panelists. First, we have Dr. Nyamai, who's a consultant anesthesiologist in practicing in Kenyatta Hospital, Kenyatta National Hospital. He is a pediatric anesthesiologist with a specific interest in sedation outside the operating theater and also in clinical audits. On top of that, he's also a mentor and good teacher to a lot of residents who are currently present on this forum as well. And then lastly would be Dr. Adembesa, who is also a consultant anesthesiologist in the Kenyatta University Teaching, Research and Referral Hospital, who's subspecialized in cardiac anesthesiology and happens to be the head of department in anesthesia and critical care in the aforementioned hospital. So very happy to have them on board. I think we'll just kick off with the question sent in a bit earlier, even at the start of the session by Dr. Misango via email, who had asked in terms of clonidine, the use of clonidine in sedation. Is there any experience that you guys have, including Dr. Gitau and the two panelists? Dr. Adembesa?
Can you hear me?
Yes, I can hear you loud and clear.
Yeah,
go ahead,
so the only experience I have with clonidine is with sedation in especially the pediatric population, children. I've used it for MRIs and it works well. We've also used it especially for pediatrics again, post-cardiac surgery when they have delirium in ICU. And it works very well. Yeah, it's an alpha-2 agonist, just like dexmedetomidine, and has some analgesic effects as well.
Okay, I hope that answers your question, Dr. Misango. I believe, should he not have any comment at the moment, we can go on to the next question posted by Dr. Lee Ngugi. He's asking, why is midazolam and morphine, the combination, so prevalent even in well-resourced ICUs in Kenya? I'll hand over to you, Dr. Nyamai. I'm unable to get a hold of Dr. Nyamai. Maybe Dr. Sheilah, you can take this question?
Yes, I could. I think in terms of prevalence of use, I think midazolam and morphine were the historically the drugs that were more available in the ICUs. The dexmedetomidine, the propofol have come in as newer agents. And I guess because of the people being more used to using these drugs, they've continued to use them despite there being newer and better drugs for the sedation in ICU. I think it's more on us now as the ICU practitioners to push and try and change these people's perception of these drugs, because most people think that propofol is a drug that should only be used in ICU, I mean in theater. And a lot of people are actually not comfortable with the dosing of these drugs. And that I think has contributed to them not using them. Because I think most people will use propofol, give a bolus dose, and then the patient becomes hypotensive, and they're like, that's a bad drug, we shouldn't use it. So I think it's on us as the practitioners to now change people's perceptions of these drugs and encourage them to use the newer agents, which are safer and better for the patient.
Okay, thank you for that. Dr. Lee, and should there be any additions or comments or anything else you wanted to add, kindly just forward to me. We can move on now to the next question by Kituu Nelson, who thanks Dr. Sheilah for the very informative presentation and wants you to comment on spontaneous awakening and spontaneous breathing trials. Dr. Gitau.
Okay, so I think the spontaneous breathing trials are done to assess a patient who's ready for liberation from mechanical ventilation. And they should be determine whether the patient is ready for extubation, and they should be done once the patient has improved, or the reason that the patient was put on the mechanical ventilator in the first place has resolved. That is, if the patient had a lung disease, it's stable or it's resolving, the patient is improving, you should be on minimal settings on your ventilator. So the patient can either be on a TP's trial or on the ventilator on what we call minimal support, which would be an FiO2 of less than 0.5 or a PEEP of less than 5 to 8. You can decide which is good, because the patient then doesn't have, you're not straining through a straw to breathe, which is why you want the PEEP on board. You want a patient who's hemodynamically stable or on very little inotropic support, and to initiate this, and the patient should be having be able to initiate their own breathing. So that's when you have you can use your rapid shallow breathing index, which is your respiratory rate over your tidal volume, to decide whether the patient is actually ready. If the patient's RSBI, rapid shallow breathing index, is less than 105, the lower it is away from the 105, the better. A patient with an RSBI of 40 or 50 is a patient who's likely to succeed a spontaneous breathing trial. A patient who has an RSBI of 99 to 100, 102 is not likely to sustain. So once the patient has fulfilled the criteria for being initiated as a spontaneous breathing trial, you can either connect the patient on CPAP, so put the patient on a pressure support of about 7 and a PEEP of at least 5 to 7, and then you monitor the patient for about at least 30 minutes to, I think the guidelines say up to 20 minutes, which I think is a really long time, to decide whether the patient has passed the spontaneous breathing trial. And it has found that 80% of patients who pass a spontaneous breathing trial will survive liberation from the ventilator. So once the patient has done more than 2 hours on the spontaneous breathing trial and they're not tachypnic, they're not agitated, the blood pressure has not increased from baseline more than 40 millimeters of mercury, the heart rate is not more than 140, and the tidal volumes are more than 325, this patient is ready for extubation. When do you say you stopped a spontaneous breathing trial? The patient has failed the spontaneous breathing trial. The patient is tachypnic, the respiratory rate is more than 38, 30 you could say. The saturation volume, they're less than 90%. The tidal volumes are low, less than 325 mils. The patient has a tachycardia of at least 130, 140 beats per minute, or at least more than 25% above the baseline. And the blood pressure has also fallen, has gone up above the baseline because of the agitation. Patient is agitated, is uncomfortable, they're sweating, and their RSBI is more than 105. then you say the patient has failed the spontaneous breathing trial. I hope that answers Dr. Ntekebi's question.
I believe so, yes. Thank you for that, Doc. I think we can move on to the next two questions are sort of similar. So the first one from Sirak just asks for how long do you interrupt? And the following one from Violet is also inquisitive on how long it should take before a sedation holiday or break, and how long should the break last? I think I'll leave that to you, Dr. Nyamai. Do we have you on?
Hello,
Dr. Nyamai.
You can hear me?
Okay, perfect. I can hear you well.
Thank you.
Well and good.
Thank you. I'm having some internet issues, but thank you, Dr. Sheilah Gitau. That's a very nice presentation. I think let's give it to Sheilah Gitau, probably. Thank you.
Thank you, Dr. Nyamai. How long should a sedation holiday take? As long as it takes to assess the patient and they're at a RASS of 0 to 1 or a SAS of, I think, -3. The idea is that the patient should be awake, able to follow verbal and physical commands appropriately. Then once you're able to assess that level of sedation, when the lightness of sedation, then you decide how ready are you to wean the patient off. Is the reason the patient was put on the ventilator or the sedation was started, have you achieved those targets? If you have, wean the medication off. The idea of a sedation vacation is to tell you when you're ready to initiate weaning of the sedation. So if the patient is able to tolerate, they're able to follow simple commands, they're not agitated, why do you need to restart the sedation? That is the question you need to ask yourself. What are your goals in doing a holiday? Not when you assess the patient and put them back on the vent and put them back on sedation. The goal is to stop the medication. Thank you.
And Doc, in terms of the approach to a sedation holiday, just to build on that, do we come in every day and do an abrupt break in the entire medication in terms of this patient was on relatively high sedation requirements? Do we come and do an abrupt withdrawal, or do we titrate it down slowly as we approach to the targeted RAS? How do we go about it?
The idea of a sedation break or sedation holiday is to do that, just that, stop the sedation. It's a neuro patient, you're trying to assess the neurological status. The patient has to be awake for you to do that. So the idea is that you stop the medication, you've assessed what sedation score they were at before, then you stop the sedation. If they're comfortable, getting a bit tachypnic, you'll restart at half the dose that you had before. So that you're trying, and then you reassess your patient. So once you're able to assess your sedation level using a sedation scale, then you decide whether you're going to restart it or not. Ideally, every day is a winning day. So yes, you're supposed to do this every day. Ideally at the beginning of your shift, so that you give it enough time for you when you're coming to reassess your patient. You make an objective decision, you have a discussion as a team, decide what your goals are for the patient for the day, and then give a plan forward for your sedation. But if the reason the patient was put on the sedation or the ventilation or in ICU has not resolved, has not improved, then you want to restart the sedation. You want to put the patient back. Say it's a patient who's a neuro patient, you've now done 24 hours, you want to reassess the neurological status, you stop the sedation, the patient is still flat. You're not going to restart the sedation. You want the patient to wake up so you can assess. If the patient gets agitated or the patient had raised intracranial pressure, you repeat your CT scan, the edema is still there, restart your sedation. So it's not just doing the sedation break, you're tying it into the clinical picture of the patient and what your targets are for the day. I think that's how I would approach it.
Perfect. I'll direct the next question by Cindy Murila to Dr. Adembesa. Kindly comment on sedation with opioids, specifically morphine and fentanyl versus benzodiazepines. Dr. Adembesa?
Your choice of opioids or benzodiazepines, I think it depends, as we said, on the patient you're dealing with. But as Dr. Sheilah has mentioned in her presentation, benzodiazepines are associated with increased incidences of ICU delirium, and so are opioids. So if you can avoid using either, then the better for the patient, especially we are talking of a situation where you're anticipating this patient might require prolonged sedation in ICU. Then the second thing is, again, depends on your patient. Is your aim more to address pain issues in these patients? I'm talking of like a post-op patient, but who is still intubated, and you are more concerned about pain as well as getting the patient sedated. So in that case, of course, you will lean more towards the opioids. Now, which opioids to use? Of course, the shorter the acting, the better. So the good old remifentanil, if you have it, it's the better, because of, again, the issue Dr. Sheilah has talked about of daily sedation interruption, spontaneous breathing trials. We know if you give morphine as an infusion for long, or fentanyl, then the context-sensitive half-time is long. So even when you want to give this patient a sedation break, you have to wait longer for the patient to wake up before you can assess the patient, compared to remifentanil. And then benzodiazepines, of course, if your patient, let's say, has undergone a neurosurgical procedure and you're sedating and you're worried about convulsions post-op, then in this case, you would want to consider, a benzodiazepine as one of your option for sedation. So in short, it really depends on the patient. But what we need to know, take-home message from what Sheilah has presented and from the evidence out here, is benzodiazepines and opioids are associated with ICU delirium, especially if you're giving them over a longer period. Thank you.
Thank you, Dr. Adembesa, for that. Dr. Nyamai, maybe if you have any input regarding the use of opioids in ICU based on your experiences, or not necessarily even ICU, but sedation outside the operating room, be greatly appreciated. Thank you.
Thank you, Dr. Abel. I think just as Sheilah has said and Dr. Adembesa, you want something that is short, onset is rapid and offset is rapid, and something, if at all the patient is in pain, then you think about an opioid. And that's the only input that I would have. And the rest is just to say that it's good, it's very important. This topic is very important because you don't want to do all this good work, and then after the patient is discharged from ICU, they can remember every single trick that they got. They can remember every procedure that was done in ICU, and there are many that are done. So it's important to ensure that they are well sedated. Thank you.
And while I have you on the line, Doc, how about if we were to mention in the context of special populations such as pediatrics, are there any differences in nuances with the approach to sedation, or is it one size blanket for all?
Okay, well, it's important that children should also be sedated in ICU. They will also have recall and all that. So it's important also to achieve good sedation in them. Thank you.
Thank you for that, Dr. I believe this answers Dr. Kasuku's question whether remifentanil is a good sedative agent. Lots of appreciative messages on the chat towards Dr. Sheilah for the eloquent presentation. Those have been noted as well. So in terms of, there's one question by Olivia Kinyanjui, who asked the mention of oral sedatives. What situations are appropriate for the use of oral sedatives, and at what level of sedation can we hope to achieve with these options? I'll hand that over to you, Dr. Gitau.
Thank you for that question. In terms of the oral versus IV sedatives, it just depends on your patient. A cooperative patient who's anxious because they're in the ICU and they're worried that they're going to you know, they might end up dead, or the patient who's anxious because they're, you know, withdrawing from something. Regardless of the route of administration, the sedative, in terms of efficacy, will still get to the patient. I mean, the idea is that what is your RAS, or what is your goals for sedation? What are your goals? Sorry, is it anxiolysis? Is it sedation? The route really doesn't matter, because that's why you have drug levels. That's why you titrate your drugs to whatever you want. So for a patient who you want to cooperate on the mechanical ventilator, the patient who's anxious because they've not been sleeping, oral medication work just as well. A nighttime pill, because their sleep-wake cycle has been disrupted, will help patients be more cooperative during the day. We don't tend to use oral sedatives as much. I think the only one I've seen is clonidine, because we didn't have the IV in the country previously, so we could use oral clonidine. But in terms of the sedation, what level of sedation we can hope to achieve with these options, the sedation levels would be as the same as would get an IV formulation. Thank you.
Thank you for that, Dr. Sheilah. So anyone else with any question asked to the panelists, feel free to go ahead now before we get into the presentation by our sponsors. Okay, should there be none, I believe we can hand the floor to you, Lauren. Lauren, once more, is a product manager for Fresenius, presenting all the way from South Africa. So we're happy to have you on. Please keep in mind your presentation should be 10 minutes. In the interest of time, I believe, since because of the Q&A, we've eaten into your time a bit, but you can go ahead so that we can wind up the session. Thank you, Lauren.
Thank you very much for the kind introduction, and my apologies for the technical errors on our side. I will be presenting to you live. Can you see my screen and hear me? So I will be introducing more than 20 years of Fresenius Kabi's propofol. A quick history. In the beginning, in 1835, the first IV anesthetic was performed by Nikolai Pirogov using chloral hydrate. In 1846, the first ether anesthesia was performed by Morton in Boston. In 1884 was the use of cocaine. And the 50s and 60s are really the beginning of modern and balanced anesthesia. So in 1952 was the use of morphine. 1956, the introduction of halothane. In 1960, the synthesis of fentanyl. And in 1966, the introduction of enflurane. The first propofol molecule was launched in 1977 by Kay in England. And in the 80s was the first clinical trial with propofol. There was a cooperation between Zeneca and Kabi to develop the future AstraZeneca propofol, which was the original propofol. Kabi is well established in fat emulsion technology. You may know some of our products such as Kabiven or Intralipid. So Kabi delivered the know-how on how to make propofol soluble in an oil and water emulsion and developed the technology to produce propofol in this emulsion. So in 1986, the original propofol was launched worldwide, and in 1997, there was registration of propofol 1% Fresenius in Germany. And this is why we celebrate today more than 20 years of Fresenius Kabi's propofol. At this time, there are two different propofol formulations. There's propofol in a medium chain triglyceride, which is called an MCT, and propofol in a long chain triglyceride, which is called an LCT. Currently, the propofol MCT registration in Kenya is still pending. At this time, more than 150 countries in the world have been supplied by Fresenius Kabi's propofol. We have sold over 1.6 billion units, and over 910 million patients have been treated with our propofol specifically. So why propofol? I think the previous presentation really did sing the product's praises. International guidelines do recommend propofol for anesthesia as well as sedation of mechanically ventilated patients. Since 2011, propofol is on the WHO list of essential medicines, and studies with propofol are ongoing in anesthesia, which documents a continuous scientific interest in the substance. Just some practicalities in the ICU. If you are to use propofol, If you are using a lipid-containing parenteral nutrition simultaneously, the lipid content of propofol should be taken into consideration. 1 ml of propofol 1% contains 0.1 grams of fat. Your maximum duration of continuous infusion is 72 hours, whereafter you would ideally assess the patient, such as the sedation vacation that you were referring to earlier. Dosage for the ICU sedation of propofol is 0.3 and up to 4 milligrams per kilogram per hour. And why do we love this drug or medicine? It's because of the rapid onset of action, short duration of effect due to its rapid metabolism and elimination, and the patients recover consciousness rapidly. I'm glad I included this slide because it really is linking with the previous presentation. Why would you use propofol versus a benzodiazepine? You have faster emergence from sedation, shorter recovery time after prolonged sedation, and it has also been shown that sustained use of benzodiazepine-based sedative regimens are associated with the development of delirium. The use of non-benzodiazepine medications such as propofol are indeed associated with improved ICU patient outcomes. So what is propofol MCT? It is a propofol in a medium chain triglyceride and a long chain triglyceride emulsion in a ratio of 1:1. Just the quick benefits: it is equally effective to propofol LCT with an induction of 30 to 40 seconds, and the duration of action after a single bolus being short and due to the rapid metabolism and excretion. Another benefit of the MCT is improved fat metabolism. The MCT emulsion allows for significantly lower plasma triglyceride levels at the end of anesthesia compared to an LCT emulsion on its own. This is especially beneficial for your patients with hypertriglyceridemia, as well as these long-term sedated patients. Another benefit of the MCT emulsion, not necessarily for the ICU patient, but quite significantly for those in theater, is less pain on injection. So less incidence and less intensity of pain on injection compared to your LCT emulsion. This is because a higher concentration of free propofol in the aqueous phase of emulsion is associated with the pain on injection. And the addition of the MCT ensures that there is less free propofol in the aqueous phase. Just a quick slide on the safe handling of propofol. The product should be drawn aseptically into a sterile syringe or giving set immediately after opening the ampule or breaking the vial seal. Administration should commence without delay. It is for single administration in an individual patient, and after use, the remaining solution should be discarded. And this is to avoid microbial contamination. A quick look at where the Fresenius Kabi's propofol is coming from. This is our plant in Graz, Austria. You can see the production line of the vials. It's the production line of the ampules. And currently your propofol 1% Fresenius is coming from Uppsala in Sweden, and this is an image of the plant here. I thank you for your time, and I do hope we can register and launch Fresenius propofol MCT in Kenya soon. Please do let me know if you have any questions.
Thank you for that presentation, Lauren. I'm sure it was greatly appreciated by the participants on board. Should we have any pending questions following the earlier discussion or related to the product presented? I'd be happy to have them on board. If not, I think we can begin winding up what has been a very engaging session so far.
Thank you very much.
Thank you, Lauren. Okay, so no further questions on the group. I think seeing as it's 7:35, we're 5 minutes past time. I'd like to, sorry, there's one late question over here. I believe this is directed to Lauren. Is the MCT propofol price the same as the LCT?
That is correct. Thank you for the question. Specifically in South Africa, where we have already launched the MCT a good several years ago, the price is the same. And for Kenya, it will be the same as confirmed by your manager here next to me.
Perfect. I hope that answers Dr. Janak. Any other questions to late additions to be added to the group chat?
can make one last comment. I just see dexmedetomidine is mentioned quite a lot. It is really a challenge, although it's a wonderful medicine. Just speaking from South Africa, I'm not sure if anyone else wanted to comment, just the affordability of that medicine. And as it stands at the moment, there aren't any clinical trials showing that it is better for your patient with respect to delirium at this stage. But it is growing in popularity, but not very affordable across the board. Thank you for your opportunity.
Thank you for that. Thank you, everyone. Thank you for all the participation in this session. Hope every other session will be like this. So just a few announcements before we close up. The CPD points to all the participants, I think local, will be sent to your emails. The certificates as well for other cadres and for international participants will be sent, we're hoping by next week, Monday or Tuesday. There are no further society-related announcements. So all I just want to do is to thank you all. Thank you to the participants for making the time. Thank you for the panelists, Dr. Nyamai, Dr. Adembesa, for engaging and answering the questions. Thank you to Dr. Gitau for such a lovely presentation. Big thanks to the webinar organizing team and the sponsors, Fresenius, Lauren's presentation. And on that, should there be no further comments, remarks, questions, I'd like to bring this meeting to a close. Thank you to all. It's been a good one. Next session, I believe, will be on the 8th, if I'm not wrong, of next month. We'll communicate that via email. Other than that, I'd like to, next week, the 8th of April. Other than that, I'd just like to thank you all. I'd like to formally bring this session to a close. Have a good night. Thank you.